Hi everyone, I'm Dr. Rosie Roeder here with my co-host
Andrea Sparr, PA.
And we are the Rejuvaness Podcast. We are going to pick up where we left off last time.
Episode 2 of skin cancer.
Yes. I think we ended up talking a lot about melanoma, which is really important.
Yes.
But we cannot leave basal cells and squamous cells.
Can't be lenient about those because they can be just as bad.
Yeah, we can't leave them out of the conversation. So we should talk about the non-melanoma skin cancers on this episode because the modality for recognizing them and treatments are vast.
Yes, and Rosie and I both treat skin cancers. We both do procedures, so we have a lot to talk about.
Yes. So we talked a little bit about signs of different moles, right? I want to start by talking about basal cell carcinomas. I think I mentioned last time they're the most common type of skin cancer that exists. They have very characteristic of them pathologically that you can pick up with your eyes, and there's definitely different subtypes, and those subtypes are very important in determining treatment.
Yes.
So you not just pay attention to the fact that they're basal cells, because not every basal cell carcinoma is the same. Nodular superficial basal cell carcinoma is going to probably be there for a really long time. It's slow growing, won't break off and kill you. And then you will have something more of an infiltrative nature that has little tentacles under the skin.
Tree roots. I call them tree roots.
They're little tree roots. So whatever you see on the surface might just be the tip of the iceberg. And sometimes patients are very discouraged when it starts off with a tiny little dot and then they end up with a big surgical defect.
That's the size of a $50.
Right, because that infiltrative nature, just think about those little roots or branches. Those branches are very difficult to see with the naked eye. These are microscopic extensions of the cancer underneath the skin. So I guess the point there is you're going to see something different and abnormal. They tend to be red, raised, pearly in nature, or they'll become an ulceration.
And they're bleeding on you every single day without even touching it.
Yeah. Like men say, I'm shaving.
Yep.
And it always bleeds. I've had a few of those. It eats away at tissue. That's what basal cell carcinoma in the advanced stage will do. Mm-hmm. So they'll create wounds that don't heal. So you got to pay attention to any non-healing wounds. Colloquially, we call those rodent ulcers. So if you think about that, it's pretty graphic.
Yep.
And it can look that way. And anything that you leave unchecked can definitely become a big problem.
And eat away where it is.
Eat away at tissues, exposed in structures underneath. Mm-hmm. And if they outgrow their blood supply, then they can go necrotic, meaning the tissues will die. And patients will come in with maggots, foul odor ulcers. I mean, all sorts of different things.
Exposed bone,
muscle. So in advanced stages, it can be pretty severe and require a lot of treatment.
Now, squamous cell, that will be our second one.
Right.
Definitely comes in different stages too. Like we talked about, cutaneous horn can be seen. It's definitely, some people confuse it for a wart. They'll come in and say, I've had this wart and it's been hanging on my ear and stuff like that. But they have a distinct kind of tell to them. Other places that we talked about, the keratoacanthomas, those are massive little spots that pop up really quickly. I usually tell my patients within the time frame of 4 to 6 weeks, the size of a nickel place has popped up. They kind of look like volcanoes erupting.
Yes, that's a great description of them.
Definitely kind of ulcerated at the top, but definitely something you need to worry about because those tend to eat down a little bit further than basal cell and they can metastasize pretty quick if left untreated.
And sometimes they spontaneously regress.
Yes.
Meaning they'll go really quickly and then they'll kind of
the body will start trying to treat them, and then they'll still be there a little bit.
Yeah, and people will say, oh, it's gone now. I don't have to worry about it. But the part underneath the skin is still there, and that still needs to be treated.
And something we didn't talk about last time was actinic keratosis.
Yes,
they're precursors to squam. Not everyone will turn into a squamous cell carcinoma. I usually say about 1 in 4 you would expect to change at some point. But they turn into that early squamous cell in situ, which is very, very easily treated if you catch that at that stage, because it's in situ means in place. It hasn't passed that skin barrier. And
right. At those patients, stage 0.
Yes.
Yeah. If it hasn't broken the surface, it can't go places.
Correct.
Yeah. So all the in situ cancers, which we use for squamous cell and for melanoma, tend to be the ones that I tell everybody, like, it's contained inside your house. Like, you don't have a roof leak. You don't have breaks in your windows. Like, it's still cutely contained in your house. So you're not, if you surgically treat it or you treat it in some of the other modalities we're going to talk about, then it doesn't have a chance to escape and go places, which is what we want. We want to get cancers treated as early as possible.
And a lot of those superficial ones you're able to treat with easier treatments, I say, versus being kind of on surgery without surgery, kind of. So even like topical chemotherapy creams that kind of rejuvenate the skin, I say, what it does is it basically sheds those layers, trying to get rid of all the abnormal cells so new cells can form. But that can be over several weeks of at-home treatment. If you have a lot of abnormal cells around there, like precancerous, patients kind of get upset because they're like, my arm is on fire.
Yeah.
But it works.
Right. I'm going to try to break it down a little bit, like systematically, about how, at least I think of it, and I think most of my colleagues think about how we approach cancer in the skin, right? So if we get something in the early stages, like an actinic keratosis, you can treat it with just cryotherapy. It's one of the most common things that we do, is that liquid nitrogen that makes it burn.
Negative 320 degrees.
Yes.
It's colder than dry ice.
It is colder than dry ice. It does cause a burn.
Yes, first degree burn, basically,
with a blister. Much. And it can blister, it can be red. It takes some time for the skin to regenerate. All these modalities that are topical like this are also like enlisting your immune system to take care of those cancerous cells. So they, in their own right, can kill some of those abnormal cells, right, by burning them off. But they're also enlisting your immune system in the repair phase of your skin, and that will clear out some other skin.
And it's triggering that to find those specific things.
Right. For people who have multiple actinic keratosis or a lot of sun damage, we can use blue light therapy.
Yes.
And that entails you coming to the office. We put an application of a product on your skin. You sit in the office for a little bit. I know some people do it differently and they give it to the patients to put at home, but I'm more comfortable with my patients sitting there.
It desensitizes the skin, so it's acceptable to that light. Yeah,
so that it can be susceptible to the blue light, and that way it will eliminate, again, signal your immune system to come and clear up the medicine itself, its effects on the cells. I prefer you stay in my office while that medicine sits on you, because then we know it's sitting on there for the appropriate amount of time. And there will be a scaling up on the amount of time that you have that product on your skin to get rid of it. And there's multiple treatments involved. But again, preventive to take care of that damage.
It also helps, like anything that's not getting taken care of without, it needs biopsy, because it's probably further along.
Right. So I tell my patients, I'll freeze something once. If it's come back, I'm probably going to biopsy it, because we could also have selected, right, for the stronger cells. Like we got rid of the cells that were precancerous and we've selected for stronger cells that are potentially cancerous. So it's okay to do some of these therapies, and we do a lot of it for what looks precancerous, but you don't want to be spraying the same areas over and over and over again without seeing much improvement, because that really means you might have a more advanced cancer. So biopsy is never a wrong thing to do if you've failed the cryotherapy, the blue light, or the chemotherapy or immunomodulator creams that Andy referenced to that you can do at home. So after that, we're going to go to the in situ cancers.
So we can talk about, again, that'd be something we can definitely use the topical chemotherapy creams on, or we can do something called an EDNC, which is destruction and curettage. And that is where we there's a specific margin around the area that we take. So I usually mark what I can see, mark the margin. We numb the patient up. And what we do is we basically scrape the skin with a curette and burn it. And you do that 3 different times in 3 different directions. And what that's supposed to do is you basically keep scraping the bad cells. Skin cancer scrapes a lot easier than normal skin. And I know there's some MOHS surgeons out there that'll do that prior to even starting their MOHS to see what direction they need to go in. But you'll get to the point where it's just not scraping anymore, and you've gotten to the level you need to be at, and then that area is treated.
Yeah. And I will do that sometimes, but I'm primarily like one of the surgeons in my office. So a lot of those treatments get done by the dermatologist, and I usually get the more invasive cancers. I don't get a lot of the in situ cancers. Mohs surgery, which we'll talk about now, is also adequate for in situ cancers. In situ cancers can be very tricky because they can be microscopically seen under the skin at a much wider range too. It's those little roots, right, that are underneath the skin that you can sometimes not see to the naked eye. But Mohs surgery is a very specialized type of cutaneous surgery, so skin surgery, where a dermatologist is trained not only in detecting skin cancer and in surgically removing it with a scalpel, right?
But reading the pathology afterwards. So like in our office, I think all of our offices, except for some of the smaller satellite ones, will have a Mohs surgeon. We have a laboratory where we will get the tissue. The Mohs surgeon will go in there, mark what they can visually see, put small margins, because one of the purposes of this is not just to be accurate, but it's also to spare as much normal tissue as procedure.
Yes, exactly. It's a tissue sparing procedure. So we want to spare as much of your normal skin as possible. So they will put a few millimeter margins on there. They will cut around it. They will mark it, and they bread loaf it. So that's looked at in multiple different planes and directions. That tissue gets frozen, it gets stained, and then they'll look at it under a microscope. It takes about 45 minutes between the time the cancer gets removed to the time it gets read by the Mohs surgeon. And then they'll be able to tell if they took out everything or not.
And I tell my patients, the best way to explain it is they read it like a clock. They write it out. If they only see skin cancer left in the 3 o'clock area, that's the only direction that they go back and take more tissue. And they keep repeating that process until it's gone.
Right. So you can come in and you can get it out in one round. I've had a patient go 9 rounds one time, or actually, I lied, 7 rounds. It was just 9 centimeters. It was pretty large at the end of it. But that is one of the most accurate ways. It's 99% effective in making sure that all the cancer is removed, which is the best statistics, right? Because nothing is 100% ever in anything in the world, right? There's always a small margin of error in anything that we do in medicine, right? Because we are not God. We are not perfect.
Right.
And, there's always a small amount of error, but it is the best technology that we have on site that we can do a tissue sparing surgery to give you the most adequate diagnosis on the fly. I can take somebody to the hospital and do frozen sections, the same thing. I can remove it, but I have to follow the NCCN guidelines. So for a squamous cell or basal cell, I'm putting at least a 5 millimeter margin, sometimes a little bit more if it's on the aggressive or poorly differentiated squamous cell type, depending where it is on an extremity. And then I'll remove it and I'll send it to the pathologist, and the pathologist will do that same process. And I usually have the patient in the operating room kind of waiting, and I'm sitting there waiting, kind of preparing for the next step of my surgery, how I'm going to reconstruct it. And then the pathologist will tell me, hey, yes, your margins are negative and you can go ahead and reconstruct. Or they'll say the 9 o'clock or 8 o'clock, you need to take a little bit more, and I'll do that. I think it's a very expeditious way to do it in the office because the patient is under local anesthesia. Almost everybody's eligible to do that. There are other times where you need to take somebody to the operating room because the way you expect that you're going to need to reconstruct ahead of time, right? If it's already a large lesion.
And they can only have so much local.
But sometimes I'll let the Mohs surgeons take it out because it's so accurate and they do such a great job. And then I'll look at the size of the defect and I'll tell the patient, we're going to have to go to the hospital to reconstruct you because this is going to be something that you wouldn't want to do awake. As long as they're healthy enough to get general anesthesia or at least some IV sedation. At times we do need to do that. If I can reconstruct them in the office, great. Yeah. But some patients are really anxious and they don't want to do anything under local anesthesia. So there are other options to do it, and we'll do that on just taking into account the patient's
And Mohs isn't warranted for the entire body. It's only specific areas that insurance tends to cover it. And it's those areas that you do not have a lot of tissue to play with, like tops of your hands, feet, face, ears. Now there's sizing on some of the other one that you can get it covered for other parts of the body, and depth for the squam or basal cell, but a majority of the time you stick to an excision for those other things.
Right, because I get that question frequently, why did I have Mohs on the basal cell on the tip of my nose, but not on the basal cell on my forearm? And I said, well, it was small enough in the forearm that I could just take it out under local in the office and you didn't need to.
And you could get mainly clear margins with the standard of care margins that we take.
Exactly. And if I have had a lot of advanced disease in my practice, I have patients that have very large, very masses on their scalp, on their face, sometimes even on their extremity, that I anticipate that there it's going to be really hard for the Mohs surgeon to even do it in the office because they're going to need so much local anesthesia for this. It's not going to be pleasant for the patient. The risk of bleeding is really high, and it's just safer to do in the operating room.
Or they're going to have so many cuts, they're going to have to leave and come back the next day for more to be done.
For more to be done. And I just want to mention this as sort of an aside because we did melanoma and we did not talk about Mohs surgery when it came to melanoma, because it's not yet the standard of care on NCCN guidelines to do Mohs surgery for melanoma. It requires very special staining. It requires these antibodies and hybridization of the antibodies. There are some Mohs surgeons out there that will do slow Mohs for in situ melanoma, the non-aggressive types. But again, I would caution everybody to speak to their dermatologist before they pick the type of surgery that they need to have to treat their skin cancers. Or if you decide that you're not a person who's interested in surgery and you will accept other modalities like we spoke of before, understand what the recurrence rates for those are.
Yep, and what the treatment cure rates are for a lot of the modalities. Because ED&C, I usually tell my patients it's around 93% cure rate, but there's nothing we send off to the lab to guarantee that we got it all.
Yes, and that is a very important point. Some people are type A like me, so you want to know that it's gone. Right? Yes. And if you do an ED&C or you treat it with topical chemotherapy, I offer that a lot for spots where I think it's going to be difficult to heal or I won't be able to surgically close. For the patient who may not be a great surgical candidate or they don't want surgery, but they have the informed consent to know that they're accepting a lesser cure rate and that we cannot verify what we just did.
Correct.
We have to do it based on what we see and then add those margins to it, right? And then follow it clinically later, which is the same thing we do with superficial radiation therapy, which is another technology we have.
Yes, that requires a lot of treatments.
It requires a lot of treatments over time.
But it's surgery without the surgery.
Right. So it has a 98% cure rate. I don't offer this to patients who are younger than 55.
Yes.
Because there is a chance that several decades later,
you'll get a skin cancer.
You'll get a skin cancer from the radiation.
Yes.
So you don't want to do this very young. But again, I have had younger patients ask for SRT and I give them the informed consent and I tell them like, you might be treating this basal cell now at the age of 30, but you might get another one at the age of 70. And some of them are so scared of surgery or so scared of the aesthetic deformity on their nose, their face, their ear or whatnot, that they understand that they might get another skin cancer there later on in life and they're willing to accept it. Well, that's just something that you have to be very clear with your patient population. But I prefer to just keep it to what we kind of have established as a guideline is nobody under the age of 55, just because of that chance of cancer later on in life. But it melts away the tumor, right? Starves it of oxygen. That's how radiation works. So it can regress. But it has to be followed clinically too. They have to understand that there will be no pathology and we have to continue to follow that spot
and there's
forever.
Still a downside to that too, because patients can have bloody noses, ulcerations.
Yes.
It can still take a while to heal. It's not all butterflies when you switch to SRT.
Right.
So I have to explain it, especially on like lower extremities for people who have chronic leg swelling. That's one of the hardest places to do excisions on, but SRT can still come with its sides as well.
Right. You just have to be very clear. We have a checklist when we offer SRT to patients as to very important things that they should know. Like, for example, the radiation is also going to kill your hair follicles, so you're probably not going to have hair regrowth. So you got to be very considerate of that if you're doing anywhere and that's a hair-bearing area. So there's lots of things to talk to patients about. I think the most important thing is have somebody who's educated in all the multimodalities that they can offer you and that they go through giving you options.
Right.
You know, because I usually tell my patients, this is what I think is the best option for you. And if they're not okay with that for whatever reason, then we can go back to the second, third, fourth options. You have to understand what you're getting out of it. You have to understand what you have to put into it because some of these treatments are driven by the individual, right? If you're going to put your topical chemotherapy or
if you're actually going to do
immunomodulator cream, I'm going to do it. You have to do it, right? And that gives you some power over your treatment. But that also means that you have to be very good at applying it. You have good instructions, so you know exactly what you're doing, because these things can be dangerous otherwise, and the length of treatment, and we have to follow you. But this may be something great for somebody for whom it's really difficult to go places or is not a good surgical candidate. Some treatment is better than no treatment at all.
Yes.
But I have patients that they decline treatment. And, we have to empower our patients to do what they think is best for them, even if sometimes we don't agree with it. My job is just to tell you what I think the prescribed treatments and indications are, and how you fit within the realm of things that we can offer you. But if somebody has late stage or advanced medical disease in other areas, they're in hospice already or in palliative care, it may be that we don't have to put them through treatment for their skin cancers. And they don't want
their quality of life to go down anymore from this.
Right. Because, unless you have advanced melanoma or you have advanced SAC, some of these skin cancers are not going to put you in your demise early on, right? Especially if you're already having other health problems.
Correct.
So this is why you need to really put together somebody that can put together your whole medical history and know all the options that we can treat you, to be cognizant.
It's really a joint effort on the patient too, because they've got to be willing to accept everything that you're explaining to them to, if they're ready to go to that next step of having it removed and having the treatments and coming back for follow-ups. And
right. It's a collaborative effort. I have patients that want to come in 25 times to get SRT, and they never want to get cut on again. And some that think that they don't want to come 25 times. They rather just get cut on, right?
Right.
So that there's a lot of different personalities, a lot of things to cater to. And I think that's important, that you see a doctor that can offer you a lot of options. They're not just boxed in on the one thing that they do. So they just try to sell you the one thing that they can do.
Yes.
Because sometimes I will sell patients on things that I don't do, that I think there's somebody else who's better at doing it.
And get them the referral.
Right. Like, I'm not going to excise every single SCC just because I can, right? If they prefer MOHS, I'll send them to the MOHS surgeon. If they prefer SRT, I'll send them to SRT. If they just want to be treated for their dermatologist with an ED&C, that's fine too. Like, people come to me for a consultation, for surgical consultation, and I don't tell them, like, you have to have me cut this out, right? I have them look at all sorts of different options that exist. So find somebody who's willing to give you all those options.
Okay. Well, I guess the main thing to remember here is skin cancer is very common. And definitely keep an eye on your skin. Make sure you consult with a dermatologist. If you haven't made that skin check appointment this year, make it. And I guess the main thing I want to say is, even if you're all about self-care, your sun care is your self-care. So make sure you're wearing your sunscreen every day.
Awesome. Self-care, sun care?
Self-care.
Or sun care,
sun
self-care?
Sun care is self-care.
Sun care is self-care.
Yes.
Okay, got it. All right. Well, I'm Dr. Rosie Roeder.
And I'm Andrea Sparr.
And we will catch you next time.